Good morning, everybody. I think it's 9 o'clock and we need to start. Remember, we have a class at 9 for half the group and 10 o'clock for the other half. The first lecture we're going to have is Introduction to Special Pops, and I am recording it. Hopefully, I can upload it. Let's see. Technology. What can we say about technology, huh? All right. I always like to start off class. Oh, by the way, my name is Cindy Hoppy. Remember, this morning you have a class for an hour, and this afternoon, those taking special pops, and it should be all these students are also going to meet with their clinical instructor to do clinical orientation. And that is part of your clinical time. Let's see what else I need to. That time for clinical orientation is at 12 o'clock. Please sign in using the chat so I can get a list of those students that are in attendance. All right, the SLOs for introduction. This is where our test questions come from. Discuss the differences between mental health and mental illness. A lot of times it's readily apparent to us if someone's having an emotional, a mental type of crisis, and sometimes it's not. So we need to look a little bit more. We need to do an assessment, and that is one thing that you're going to learn in this course is how to do a mental status assessment, and you will be doing it on patients in the clinical area. The second one, describe criteria for admission to a psych facility, the types of admissions and facilities where treatment may occur. The big thing is that we need to protect our patients. They are considered a vulnerable group, a vulnerable population. And we have many people who assess the patient so that everyone knows this patient needs to be seen, needs care, and it could be at different levels. Those that are a threat to themselves, others are gravely disabled, of course, would go in an inpatient setting. Those that are in a crisis, but they're not suicidal, they may be seen in a partial hospitalization group or maybe outpatient. So really, we need to know exactly how severe that patient is regarding their behavioral health status and get the right care. And many people, such as an involuntary commitment, you need to have a bunch of different healthcare providers that are looking at the patient, assessing them to make sure that this is the correct type of level of care and type of facility. The next one, discuss the significance of values, beliefs, adherence, non-adherence. A lot of our patients are non-compliant, mainly because they don't like the medicines. They feel like they don't need to be on medicines. And the brain is an interesting organ because when our patients are taking their medicines, they feel better and they don't realize they have a mental disorder and that they need to be on their medicines, which leads to non-compliance. Also, when you have alcohol and drugs in the picture, they can really decompensate really quick. And so they don't realize how dysfunctional they are. Also, values and beliefs. Historically, you know, families used to take care of their psychiatric relatives at home. However, the states, the federal government got together and said we could do a better job than families. And so we had the use of hospitals. And they stayed there for years. And they got institutionalized so bad that they had problems when they came out the hospital. So there's a movement historically to try to manage individuals uh, based on the level of care that they need. And we had a lot of community mental health clinics, and the National Alliance for the Mentally Ill also had day programs. And so we want patients to stay out of the hospital. We want them to become functional. And a lot of our patients that have schizophrenia and mood disorders, anxiety disorders, can be managed outpatient, but they need to have continuity of care. And that's one thing in the real world we have issues with. And we also have issues where healthcare providers change medication on the patient. And we all know that a certain medicine is going to work for certain patients. And this, based on what they have in the clinic as far as medications, may not give the best compliance as opposed to other ones. Also, I wanted to talk a little bit about different cultures. You know, we have a lot of beliefs in various cultures, and so we need to know where that patient, where that family is coming from. For instance, you know, in some of my older readings, those that had come from an Indian culture, they believe that having hallucinations and delusions is a rite of passage into adulthood. And yes, they go out um, into the dry climate area and can have these things. And so whether or not that group believes in that or not, we just need to understand what their beliefs are. And I can talk a little bit more individually to people about this. Discuss the relevance of altered behaviors in the mentally ill patient. You're going to be learning about them throughout the semester. Describe differences in treatment approaches between the medically and psychiatrically ill patient. With the medical patient, the focus is on the physician and physical therapy, occupational therapy, speech therapy. In the psych setting, we have the same thing, but we also, and you may have social services also involved, but in psych, just like in a rehab setting, those of y'all who work rehab, it's a team approach, and it's a multidisciplinary treatment plan that these patients have. And truly, the patient is considered part of the team. And in some cases, if family are allowed to be part of that group based on confidentiality and what the patient desires, then those people are also involved in the treatment plan. And identify interrelated concepts associated with mental illness. Cognition is a big thing, a big issue, whether it's a physiological illness, you're going to be learning about how early signs and symptoms show as a change in cognitive status, change of awareness. So we're dealing with cognition, we're dealing with behaviors, substance abuse, personality disorders, abuse and violence, domestic violence, and stress and coping, which is the last class. However, I think students can appreciate the issues that people have in dealing with society and dealing with their environment as far as stress. And mood disorders. Mood and anxiety kind of goes hand in hand, and that is probably the most prevalent of the mental disorders, the behavioral disorders that you see in the community. All right, some characteristics of being mentally healthy. Well, the big thing is that, let's go down, able to accurately and clearly apprise reality. Is their thinking reality-based? being able to control their behaviors, the one above that, consistent with cultural norms and values. The ability to relate to others and manage conflict. Because, if they, what I call a short fuse, and, they just uh, start acting inappropriate and behaving inappropriately, that can get them into some type of legal issue. So if they're able to manage conflicts, manage disappointments, maintaining self-concept and self-esteem. We all know that our self-esteem might take a hit when something happens in our world that really does affect how we see ourselves. But hopefully people will bounce back. We're talking about people who are hopeless, hopeless, uh, issues with suicide and mood disorders, where we can help these people get back to their baseline. The ability to work and be productive. A lot of people who are on uh, Social Security could be as a result they can't work anymore because their psychiatric disorder really affects their ability to function. And what we want is that they're able to get rehabilitated, they learn the skills they need to get back in that work environment. But it might be too stressful for them and they can't do that. So a lot of patients may be disabled as far as employment status. Assume responsibility for themselves. They have to be accountable for the behavior, the things that they do. The ability to laugh and play. And I love to stop here because students need to have a way to play. I know y'all always say, I gotta study, I gotta go to work, I don't have. What is the what do you mean by play? You need to recharge yourself, just like the semester break. Faculty hopefully have recharged themselves. Students too. That's why we do give breaks. That's why we don't look at emails on the weekend, just like Miss Smart said. What do you do for fun? Don't be surprised if I ask you during the semester, what do? You need to be able to recharge yourself. Possess a self-defined spirituality, whatever that is. What do you believe in? Where do you get that energy to recharge yourself? What do you rely on as far as coping? And be resilient. Children who have gone through terrible situations in their life they can become resilient. They rely on other things. Maybe their parents are not the best influence for them, but maybe a teacher, maybe the school nurse, maybe it's a friend's mother or father. So there are ways that even though they go through traumatic things, they can be very, very resilient. And we could expand on, who's important for them, who is supportive to them. Okay, so these are the characteristics of mental health. Oh, what happened here? I don't know what happened there. What gives the impression a person is suffering from a mental illness? Well, we can look at three things. Feeling, thinking, and behaving. And a lot of our cognitive behavioral approaches now look at tackling one area. And if you deal with one area, then you know there's going to be changes in the other two areas. So feeling, you ask them, how you feeling this morning? And it has to be like an adjective, a descriptor. I feel sad. I am happy. I'm disappointed. Some students may be disappointed about not getting the section they want, but that's a short-lived, and they get to see that, there was a reason why that happened. That's my belief system, that everything that happens, there is a reason for that. Thinking, are they reality based? Or are they delusional? Or they hallucinate? You'll learn more about those terms as we get into the mental status assessment. And behaving, can they control their behavior? Are they impulsive? So feeling, thinking, and behaving are some areas that we look into to see where the issue is with patients. And the big question is, are they able to take care of themselves and work and take care of their children and live life? So, can they adapt? All right, you need to know this information. Criteria for inpatient psychiatric admissions. The big thing is danger to self, such as a suicide patient. You know, I have the gun, it's in my lap. I have the gun is loaded, and I'm about ready to, you know, just say this life isn't worth living anymore. You know, actively having suicidal thoughts. Danger to others. I'm gonna kill my father, my mother. You know, I cannot control my impulses anymore. And, you know, a threat to others, or gravely disabled. Think of an Alzheimer's patient that they might find on I-10, that they're not taking care of themselves, they are confused, how in the world did they get on the interstate? That's another situation. And that is something that patient needs to come in to be better evaluated. And we may be looking at somebody who has Alzheimer's or has cognitive impairments and they can't take care of themselves anymore. Types of admissions. We have a big legal issue in behavioral health. Patients that know they need to come in for inpatient care will fill out a form. It's called a formal voluntary admit. They admit themselves. What we need to be aware of is that at any time a patient wants to be discharged, they have to give the facility 72-hour notice. And there's a form, 72-hour notice, that they want to be discharged. Why we have that 72-hour notice is so that the staff, the healthcare provider, can determine whether or not they still need to be there or not. If they really need to be there, threat to self, others, or gravely disabled, we will go into an involuntary status through a certain, you know, legal papers based on assessment. So formal voluntary is where we really want the patients to be. Remember I said patients are part of the team, and we want them on board to talk about, to work with us so that we can give the best level of care and get them out of the hospital functioning much better than when they came in. All right, the involuntary admit. This is usually patients that family members say, you know, they wheel in a gun, they have a knife on them, I'm really scared to death, they can't live in my house anymore. They need to be admitted. And once they are admitted, they usually go through the emergency room. And a physician in the emergency room, and yes, nurse practitioners and physicians' assistants could do that physician emergency certificate or this PEC. They usually, when they come into the ER, they need to be seen within 12 hours. They looking at the criteria, gravely disabled, threat to self or others, to go ahead and get that certificate started. Now, within 3 days, if they still at that status, if they have not changed back to a formal voluntary, then the coroner or the coroner's office or whoever's designated for the coroner will come in and fill out a CEC. So if the patient was on methamphetamines, and all of a sudden they cleared up and they speaking more rationally and stuff. They sign a formal voluntary. That stops that involuntary process. And they could be discharged. You know, if they're not a threat to self, others, gravely disabled, they could be discharged. But if they still delusional and hallucinating or whatever, a CEC is going to be filled out. It's a form. Y'all need to look at these forms when you come into clinical. And that's at that point, they will go through the legal system over in St. Tammany Parish, is the 22nd Judicial Court up in Covington, where they would get a date for that individual, and usually a patient advocate goes with them along with the physician if they want to, well, I'll take that back, to determine whether or not they need to be judicially committed, okay? So that's at that point, they can't be discharged until the doctor and the judge gets together to determine they need to be discharged. All right, and non-contested is those people that can't make a legal decision regarding their admission status. But however, we're trying to get them eventually to a formal voluntary. So we have a formal voluntary admit that they can stay like that the entire hospital stay. Just be aware that we have stopgaps if they want to leave ahead of time, and they need to sign a 72-hour notice where the staff can evaluate to determine if they can be discharged, maybe to a lesser level of care, or do they really need to stay in because of the threats there. And then that's what goes into the PEC-CEC. All right, non-contested, a person who does not have the capability to make a knowing and voluntary consent. If you want to specifically look at these laws, it's the Louisiana Revised Statute, I think it's 28. They have a listing of all, you know, the definitions of all these admission criteria for testing purposes. It may confuse you even more if you look at them. But I know we have some students that may have had some experience with this with family members, or in the future, they may have issues with family members. So that is where you would go. That is how we deal with patients that have behavioral health problems. All right. An order of protective custody. This is a piece of paper that families can generate through the coroner's office to get the police or the crisis unit out to pick up, out to the home, to pick up the affected individual and bring them in to a facility, an acute care facility, so that they can be assessed within 12 hours. Threat to self, others gravely disabled. Some family members feel like they can bring their loved ones in, but if they combative, they got a knife, the family's fearful of their safety, then they can go through this process through the coroner's office. Order of protective custody. All right, here's an example. Now, y'all email me or use the discussion board if you're still confused about this, because it's a lot of legal terms. And really, it based on what's happening with the patient, their admission status can change real quickly. So we have an affected person that signs a formal voluntary. Okay. They know they got a problem. They want to come in and have treatment. Then all of us, that's one example, and they can stay like that until discharge. The next one, sister seeks an order of protective custody. So there's something in the home. The sister's real concerned about their loved one, and they seek an order of protective custody. then that means the police or some legal entity within the police department. In New Orleans, they have a crisis team, and other parishes may have the same thing. Uh, the affected sister is admitted to the emergency department. The physician knows they're either a threat to self, others gravely disabled, or all three, and that they would be admitted with a PEC. Then within 3 days, the coroner will come out, and if they think they're a threat, then they will sign a coroner's emergency certificate. And then it starts that judicial commitment. Now, at some point before it gets to the judge, we see that the affected sister signed a formal voluntary. So that stops that process. After the judge makes a judgment there, then the patient really has no rights at that point, that they are a judicially committed person. But before that process, if they sign a formal voluntary, that would be fine. However, in this situation, once she signed a formal voluntary, then she says she wants to leave. So with a formal voluntary, you need to have a 72-hour notice to leave. All right. And then the psychiatrist at that point will determine whether or not they can be discharged or they have to go back into this involuntary status. I hope that clarifies it for you. All right, types of facilities. I've already talked about the crisis line, the crisis team in Orleans Parish, the coroner's office. We have some physicians that are on contract with the parish coroner's office. It may not be the coroner for that parish. It could be a designated person that will come to the facility to do a CEC if that's what needs to be done. But usually patients might be at a crisis clinic where someone could do a PEC. They could be at a hospital where something is happening where they have to do a PEC. Or they go, usually the route is going into the emergency room. There's a crisis. They come in inebriated, whatever, and that where a PEC will be generated. So we have inpatient facilities. I go to River Oaks with Miss Mose. We have other, East Jefferson has a unit. St. Charles General is an inpatient unit. We have many outpatient facilities in the greater New Orleans area. We have Seaside, Beacon, Oceans. There are other programs too. Now we have intensive outpatient programs. And an example of that would be someone has a positive drug screen at work. Through the employee assistance program, they may say, we are offering you a substance use program that's in the evenings for so many days. So it'll be an intensive program. They would not stay at a facility, but they would have to show up every day for a certain period of time. Also, partial hospitalization programs where they have more intensive treatment. Now, residential treatment programs. Those are programs where, for instance, let's think about a judicially committed patient who has been in an inpatient setting for a very long time and they need more care. They may go to the facility we have in the state of Louisiana is up in Alexandria. But even there, they have like group homes for those individuals. You know, the judge needs to be involved with that. With alcohol and drug treatment, you will learn about triggers, that you can't go to the same people, places, and things that you did prior to your hospitalization, because the trigger is so so it's like, you know, they go back to those same people who use, they consider friends, but they backslide. And so some residential treatment programs can help individuals stay clean over a period of time. And it gets them out of the area where they're coming from, you know, the community that they live in. I remember going to Destin a couple of years ago, and all those Goodwill type programs on Highway 98, I think it is, um, are really residential homes that have this business. And I thought that was neat, you know, um, that they have these programs. They're trying to get themselves back on track, and they're trying to stay away from those people, places, and things that are triggers for them. All right, I think we talked about this already. The nursing role. Our role, our big role is to give medications, look at side effects, and provide that input to the team, and also make sure they stay safe in the environment. Remember, we're going to have a bunch of inpatients that have very, very different behavioral problems, and we need to make sure that we are cueing into patients' behavior. If someone's escalating in behavior, we need to manage that kind of way. Try to separate that patient from what we call the milieu, the environment where the patients live day to day while they're hospitalized. So we're looking at impulsive and escalating behaviors. The nursing role is that we're supposed to stay calm. You know, we need to be neutral, but we need to be engaged with patients. The nurse needs to go out on the unit and talk to everybody, see how they feel, what's going on, what kind of issues they have. As students, we never go into patients' room. You're going to stay in the day room, okay? We cannot control what happens in that room. So you stay in the day room. Note escalating behaviors and intervene quickly. You're going to use some therapeutic communication techniques that are going to help you and the patient deal with behaviors. We're going to try to get them more compliant, accept, be accountable for their behaviors, and give them the restrictions that they need to help. Do they need a PRN? That's medication to help them become more comfortable, decrease their anxiety. Another thing, on the unit, we want to make sure that there's a way to get out of the room, whether it's a student or a patient, you know, so nobody blocks that doorway. There are some patients with schizophrenia that when more and more people come into a group setting, that they get extremely anxious. You might see them stay by the door. You know, that's fine if, you know, they're comfortable there, but the doorway needs to stay open so people can leave when they need to. Give the patient some space. You know, a lot of our patients walk off their anxiety, so they pace. And sometimes that's fine. But if you see that's interrupting the milieu, maybe you need to intervene. And anytime you see any change in behavior, you need to let the staff and the instructor know, okay? We are guests at the facility. We do not intervene. However, we want to make sure you stay safe. If there's altercation, an increase in anger or impulsive behavior, we want you to get away from that patient. Tell the staff. You know, they will section off the rest of the patients from that individual. Try to talk them down. Try to get him or her to take a medication. And maybe they need to go to their room. The worst thing is that we do all the measures we can to try to control the situation. And we may need to use restraints, but I haven't seen restraints being used in a very, very long time. Differences between a medical and the mental health treatment. What we use, our cookbook, is the Diagnostic and Statistical Manual, the 5th edition. And yes, we have one at school. You can also Google this to find out what is the criteria for someone to be diagnosed with schizophrenia, or the subtypes of schizophrenia. What about major depressive disorder? What about bipolar or anxiety or PTSD? So that is the cookbook that you need to refer to. And they usually say, this is the criteria you need to see in order to make this diagnosis, and having this behavior over a certain time frame. So nursing is the eyes and ears for the team. You know, nursing may have more, not as the direct care as you see in acute care setting. We do have psych techs that do the activities, help patients with their morning care, bathing, getting their trays. Some of the techs may also do groups. Nursing, we usually do health-related type groups. So groups are related to the type of expertise the person has. So we have social workers, we have master's prepared nurses, we have psychologists, we have psychologists, we have play therapists, which is really kind of interesting, that also involved in the treatment team. On this slide, I'm also pulling, we have 2 books. We have the Pearson Volume 2, which has most of the psychiatric content in, but I really recommend you would purchase the Small Care Plan book. It is, down and dirty type of information you need to take care of these patients. And that's the one I'm referring to, that Small Care Plan book, page 305, for seclusion and restraints. But we do not use a lot of restraints anymore. We used to restrain people all the time 20 years ago. That is not happening. And if we can get the patient on board and trying to change their own behavior, that's great. That's what we want. All right, interrelated concepts. You're going to be learning about a lot more concepts at level 2. And a lot of them interrelate to a psychiatric patients. You may not like psych clinical, and as far as I'm concerned, that's fine. You've got 6 days to get through it. I hope you stay open to taking care of these patients, because these patients are all over. They're in acute care. They in treatment programs for stroke, issues where there's brain involvement. We have kids that have problems just as much as adults. And so, always look at that patient holistically so you can give the best care you can. And I know you can do that. I tell you what, I'm going to get off. The lecture is over, but I'm going to stay on if anybody has any questions. Thanks, guys. And good luck this semester.
Thanks, Dr. Hoppy.
Thank you.
Thank you.
I have a question.
Yeah, who's talking?
Lacey Muller.
Okay. All right, Stacy. What?
So Lacey, I have Miss Mose for psych at River Oaks. In our syllabus, I think I'm reading it right. It says we wear navy blue.
Yes, navy blue scrubs.
Okay, thank you.
Yeah, my group does too. Navy blue scrubs.
Okay.
Dr. Hoppy, it's Deanna. Hey,